So good afternoon, everyone, and welcome to our webinar entitled Changes to the 2016 Federal Nursing Facility Regulation. What's proposed, what's final, and what to do about it. I'm Robin Grant, Director of Public Policy and Advocacy at the National Consumer Voice for Quality Long-Term Care, or Consumer Voice for short. The purpose of our webinar today is to give you a beginning understanding of what revisions to the current federal nursing home regulations are being proposed and the changes that have actually been made to the rule on nursing home arbitration agreements, which is now final. So joining me on today's webinar, we have Eric Carlson, who's directing attorney with Justice and Aging, Toby Edelman, senior policy attorney with the Center for Medicare Advocacy, and Lori Smentanka, who's the executive director here at Consumer Voice. Some of you may remember that 3 years ago, all of us teamed up to present a webinar on the revised federal nursing home regulations published in the Federal Register on October 4th, 2016. So that was the first time the regulations had been updated since 1991. These revised rules were literally years in the making and the result of multiple opportunities for groups representing a range of interests to express their perspectives and concerns prior to issuing the proposed rule. The 2016 regulations contain important new protections that better promote quality of care, quality of life, and residents' rights. So just to name a few, there are improved protections against abuse, neglect, and exploitation. There are stronger protections against evictions, and there's a greater focus throughout the regulations on person-centered care and addressing a resident's individual needs and preferences. The regulations were to be implemented in 3 phases. So phase 1 rules were implemented November 28th, 2016. Then a year later, phase 2 regs were implemented. And then phase 3 regs were to be implemented November 28th of this year. And I'll say a little more about that later. Pretty much as soon as the regulations were released, they came under attack. The nursing home industry claimed they were excessively burdensome. Right from the get-go, the American Healthcare Association, which is the trade association that represents primarily for-profit nursing homes, immediately sued the Department of Health and Human Services over the ban on arbitration agreements, and a federal court subsequently blocked the provision from going into effect. So signs of a push to roll back the regs began early. In 2017, CMS sought stakeholder feedback on eliminating or modifying certain regulations, and it then published a proposed arbitration rule to reinstate the ban on arbitration agreements, and even worse, to allow facilities to use these agreements as a condition of admission. We also saw members of Congress urging CMS to ease up on the regs, and the administration began its initiative called Patients Over Paperwork, which had as its primary goal to reduce the burden on providers. So during this entire time, advocates have been pushing back to try to stop the rules from being gutted or weakened. We've been meeting with CMS really at the highest levels, meeting with members of Congress, meeting with the Office of Management and Budget, and talking with the media. So approaching this from many different directions. And that brings us to where we are now with proposed rules, sadly, from our perspective, that would indeed eliminate or weaken important protections. So the preamble of the regs, and that's the text that describes the revisions that are being proposed and lays out the rationale for those revisions, is extremely clear about what the goal of the revisions is. As you go through the preamble, words like excessive, reduce, burdensome, eliminate appear so many times that I finally decided to make a word cloud out of them. And on the next slide, you'll see what I ended up with. I didn't make this happen, but reduce appeared all on its own as the major focal point of this word cloud, and that sums it up pretty well. So next slide, please. Oh, let's see. Where's the agenda? Well, let me just tell you about that. Here's what we have planned for you in our time together. What we want to do is provide you with a brief, high-level overview of the proposed rules. So thank you for the agenda. There you can see it. You can see that Eric, Toby, and I have divided up the sections of the proposed regs, and we're each going to discuss the language that would be revised or eliminated in those regs in the sections that you see on the slide. After that, Lori will talk about the changes that have been made to the arbitration rule, which, as I said, is now final. And then we'll give you some time to ask questions and end with pointing out action steps that all of you can take to advocate against these rollbacks. But before we start, let me cover just a few logistical details. Right now, all of your lines are muted so everyone can hear without background noise. We will answer questions after we've presented on both the proposed rules and the arbitration rule. But if, as we're speaking, you have a question prior to our formal Q&A time, feel free to go ahead and ask it whenever you like by typing it in the Q&A box. And you can open that box by clicking on the Q&A icon at the bottom of your screen. And just a note, we're not able to monitor the chat box for questions. So if you want to ask a question, please make sure to write it in the Q&A box. And one last note, because I know people always want to know this, we'll be recording the webinar, and we will be making both the webinar recording and all the PowerPoint slides available. So I think that's enough about logistics. So let's talk about what's proposed. So I think to sum up what's proposed, the takeaways for everyone are really that the proposed rule would indeed weaken or eliminate many current rules. And while I would say that the proposed changes are not as comprehensive as they certainly could have been, residents would definitely lose numerous protections. So let's look at some of these regs. Next slide. Okay, we'll start with grievances. The 2016 regulations made a lot of really significant and good improvements in the grievance requirements. So the current regs are really much stronger, more robust than they were in the past, and from our perspective, really serve residents well. Unfortunately, the proposed rule would gut several key provisions. So to begin with, as you can see on the slide, there's a distinction that's now, or would be, I should say, made between general feedback and grievances. So let me just back up and say that currently residents have the right to voice grievances regarding a whole range of issues. So the regulations say that grievances include those about care and treatment, behavior of staff and others, and other concerns about a resident's stay. The proposed rule, though, would significantly limit, in our opinion, what residents can express as grievances by differentiating between so-called general feedback and grievances. So you can voice concerns about grievances and have rights that go with those, but not with general feedback. So in the preamble, CMS states that this general feedback stems from general issues that can typically be resolved by staff present at the time a concern is voiced. And then it contrasts that with what the preamble says grievances are. They are more serious or supposedly more serious, and generally require investigation into allegations regarding the quality of care. So another point to be noted is that in the preamble, it also says that it's going to be up to the facility to define what's a grievance and what is considered general feedback. And then that has to be included, that information, in the grievance policy. So we're troubled by this for many, many reasons, but one of them is that it appears that rights would only be associated with grievances. So at the bottom of the slide, you can see where I pointed out that the right to voice grievances to the facility and other agencies and entities really seems to apply only to what the facility defines as grievances and not to general feedback. So that would apply to other rights as well. So the right to voice grievances without fear of reprisal would exist, but that wouldn't seem to apply to the right to voice general feedback. It wouldn't appear to have the same protections. Grievances have the right to prompt efforts by the facility to resolve them. We wouldn't see that with general feedback. So none of these rights would apply to the general feedback concept. So we're worried that this entire distinction is going to end up dismissing, discounting, and ignoring many concerns that residents have. Next slide, please. The proposal would also eliminate the position of grievance official, although I will say that it would still require that an individual oversee the grievance process. But CMS notes in the preamble that the responsibilities for the grievance process can be spread out over multiple staff persons, even though the rule technically says individual. So in addition, all the specific duties that were required of the grievance official in the current regulations would be deleted. And those are the very duties, I think, that help make the grievance process under the current regulations so much stronger, because it really specifically said what had to be part of that grievance process, which would no longer necessarily be the case. And it would be, in fact, up to the facility to decide what the person overseeing this grievance process would do. Next slide. So not only would the specific duties of the grievance official be removed, the majority of the information that currently is required to be included in written grievance decisions would be gone as well. So the resident would get whatever information the facility considers to be pertinent. And the proposed rule indicates that this would include a summary of the findings and any corrective actions, but you can see on the slide that all the other information that must currently be in a written decision would not be included, and that would be entirely up to the facility whether it wanted to include that information or not. Next slide, please. Okay. One last thing about grievances is that currently the facility has to keep documentation, evidence of the grievance investigations and results for up to 3 years. The proposed regulation would really cut that back from 3 years to 18 months. Next slide, please. Okay, the next section where there's a proposed change has to do with transfer and discharge rights. Next slide. So as those of you who are ombudsmen know particularly well, currently the regs say that the facility has to send a copy of the notice to a representative of the Office of the Ombudsman before a transfer or discharge. So this is extremely broad. And through guidance, CMS has indicated that only notices for what it has called facility-initiated transfers or discharges need to be sent to the ombudsman. So in the guidance, the current guidance, it talks about facility-initiated means it's a transfer or discharge that the resident objects to, which did not originate through a resident's verbal or written request, and or doesn't align with what the resident has stated his or her goals for care are and his or her preferences. And CMS has been saying right now that when a resident is temporarily transferred on an emergency basis to an acute care facility like a hospital, the notice can be given to the ombudsman when practicable, and that could even be in a list of residents on a monthly basis. The proposed reg, however, would require notices to go to the ombudsman only for facility-initiated involuntary transfers and discharges. So the guidance language about facility-initiated would be adopted in the rule. But the term involuntary, frankly, doesn't come from the rule or the guidance and isn't even defined anywhere. So it just popped up out of the blue. The proposed reg also says that ombudsmen would no longer receive the notices or information about emergency transfers to an acute care facility when return is expected. So that monthly list that I just mentioned would no longer be provided to the ombudsman, nor would any type of notice about residents who are transferred to an acute care facility when return is expected. So change there. Next slide. Okay, next up is nursing services. I'm actually relieved that there aren't more changes being proposed to this section. But the change here applies to nurse staffing data. And just as a quick reminder, that's the information that has to be posted on a daily basis at the beginning of each shift. And it's supposed to include the total number of registered nurses, licensed practical or vocational nurses, certified nursing assistants, and the resident census. So currently, that data has to be retained for 18 months in the facility, but under the proposed rule, the amount of time that facilities would be required to maintain that data would be reduced from 18 to 15 months. Okay, next slide. And this is the last point that I'm going to cover. Let's move on to the next slide as well. Thank you. The facility assessment, just as a refresher, is an assessment that the facility has to conduct on a yearly basis in order to determine what resources it needs so it can competently care for its residents on a daily basis and also in emergencies. So facilities are required to thoroughly evaluate their resident population and in fact all of their current resources, including things like supplies, equipment, buildings, to look at it all and then figure out what resources are necessary to provide for the needs of residents. So the assessment is the foundation for the care that the nursing home provides. And the guidelines actually note that it's the foundation for determining staffing levels and competencies. So super, super important Right now, it's required to be done at least annually. The proposed rules would change how often that assessment is done, from yearly to every 2 years, which we feel is much too long to go, since the determination of staffing levels as well as other resources the facility has to have depends on that assessment. So really concerned about that time frame. Next slide. One other proposed change related to the facility assessment would be the elimination of the requirement that it has to include what's called a facility-based and community-based risk assessment that uses an all hazards approach. This change is a bit odd because it's actually not in the proposed rule itself, or at least not where I could see it, but it's buried in the preamble. And the reason in the preamble that's given for deleting this provision under the facility assessment requirement is that doing this type of risk assessment is also required under the emergency preparedness regs, and this would be duplicative. So that's the reasoning that's given. So that's those are the sections that I'm covering, and so with that, I'm going to turn things over to Eric.
Thank you very much, Robin. I'm going to be covering 3 sections. The first is obviously behavioral health, and then the other 2 relate a little more directly to systems within a nursing facility, dealing with the quality assurance, and then the compliance and ethics. But let's start with behavioral health services and move on to the next slide, please. The changes here, I think I can say, are relatively limited. The majority of the language remains, although of course in matters like this, it's not a matter of counting words and see how many remain. Behavioral health services has a relatively broad coverage, relates to the references to mental and substance use disorders, psychosocial adjustment difficulties, angry or depressive behaviors, and particularly relevant in nursing facilities to references to dementia as well. And the changes here are 2 specific ones where language is deleted. First is language at the very beginning of the current regulation relating to the highest practicable well-being of residents and assessments in relative acuity, resident acuity. What CMS says in the explanation is that this essentially repeats language from the nursing section, which is more or less true. Secondly, CMS proposes to delete language relating to rehabilitative services, and saying similarly that language, almost identical language, is found in the section specific to rehabilitative services, which is true as well. So there's something lost here, but I also, in talking about, I want to make sure to emphasize what's remaining, and the slide doesn't point out the fact that the regulation does still retain some references to the highest practical mental and psychosocial well-being. So there's some of that language retained in the regulation, even though the specific provision that I discussed earlier is proposed to be being deleted based on supposed duplication related to other sections. So let's then move on to the next slide and the next discussion relating to quality assurance and performance improvement, so-called QAPI. Here, what CMS is proposing to do is to eliminate a lot of specific actions. It's similar to some of the provisions that Robin discussed. The grievances, for example, there's some similarity here. What CMS is retaining is the mandate to accomplish certain things, but is deleting a lot of the specifics about what facilities are mandated to do. And as Robin suggested, that raises some issues. If you aren't able to enforce specific actions, then it's maybe easy, in cases unduly easy, for facilities to say, oh yeah, we comply with that by doing some relatively limited activity that arguably addresses the goal, but doesn't really do a good job of attacking the problem that's meant to be addressed. So in QAPI, I'll address the 3 subsections where this comes up. The QAPI proposed regulation would retain the requirement that a facility in the QAPI program address the full range of services at the facility, but then the regulation would no longer specifically reference care and management practices, clinical care, quality of life, resident choice, and evidence of quality that reflects some processes that have been shown to be beneficial to residents. Similarly, the regulation under the proposed language would require that the facility address feedback and monitoring, but there wouldn't be any specific requirements related to input from staff and residents. And you can imagine that you'd like to think that would happen, and you'd like to think that requiring that would be reasonable and appropriate. Also eliminated is a specific requirement to have systems to collect information and to monitor adverse events. And then finally, regarding QAPI, on the next slide, there is a retained requirement that the facilities QAPI program address performance improvement through analysis and action, but the regulation would no longer specifically reference how to use a systematic approach, how to develop corrective actions, and then how to monitor effectiveness. Then moving on to compliance and ethics, and they're related here. We can skip one slide further, please. They're both internal facility processes to monitor the facility's actions and to push for improvements. Quality assurance is just what the title says, focused on quality and improvement. Compliance and ethics is focused more on compliance with law. So it's specifically meant to ensure that the facility does not cross over the line and conduct illegal activities. So again, the program would be retained, of course, but again, the review would be less frequent. Rather than having an annual review of the compliance program, the facility would only be required to do a quote-unquote periodic assessment. There would also be the similar to Robin's discussion of the grievance officer, the proposal would be to eliminate the requirement that there be a contact person for receiving complaints, and facilities instead would have more discretion to determine how to construct their systems. The existing regulations require for entities or corporations, partnerships, business entities of some sort that have 5 or more facilities, there's a requirement that they have a compliance officer and a liaison, based on the observation by many that there's some significant problems with these multi-facility chains oftentimes, or that it's important for chains like that to have some sort of coordinated program rather than treating in each facility as a completely independent operation, which it's not in these situations. But under the proposed regulation, then the entity would have more discretion. This is the multi-facility entity would have more discretion, and then each facility would just be required to assign a specific person to oversee compliance. The current regulation, as far as the overseeing of these processes is concerned has specific references to persons such as Chief Executive Officer or persons from the Board of Directors. The proposed regulation would eliminate those specific references to CEOs or directors. And moving on to the next slide, there's an issue regarding training. This also relates to the multi-facility entities with 5 or more facilities. Currently, there's a requirement that those entities conduct annual training on their compliance and ethics programs, and that would be eliminated. The regulations would retain the less specific requirement that facilities communicate the program standards, procedures, and policies. And the next slide, please. There's some other discussion by CMS as to other resources and other options. In the discussion, CMS refers to the Health and Human Services Inspector General guidance on compliance programs, which have been developed over the years to be enforced against facilities, oftentimes in settlements of cases regarding grossly substandard care. And so that those can be good resources as to what an effective compliance program should look like. And then just in closing my discussion of compliance and ethics programs, to keep it in context, I want to walk through the requirements, the existing and continuing requirements under the federal regulations of these compliance and ethics program. You can move on to the next slide. The policies have to be designed, of course, to reduce criminal and civil violations. Need to be folks to oversee compliance. Not surprisingly, need to be adequate resources. Also not surprising, no delegation of authorities to persons likely to commit violations. Yeah, of course. And there has to be steps taken to educate the staff and other folks working with the nursing facility about the program. And then going on to the next slide, also some reasonable steps to achieve compliance, appropriate disciplinary procedures, including some discipline for failure to report. You continue to require a system to accept anonymous reports, and then some ability to modify the program as necessary to respond to violations. So some ability to accept feedback and adjust as events unfold. And so with that, then I'll pass control over to Toby to talk about some pharmacy issues and some other matters.
Okay, thank you, Eric. The proposed changes we've been discussing so far this afternoon are all part of what CMS calls a deregulatory action that is intended to save hundreds of millions of dollars annually. From my perspective, there is nothing in any of these proposed changes that is intended to improve care for residents, and consequently, there's nothing that will actually improve care for residents if these regulations become final. There is one change in the pharmacy services, and this relates to the issue of PRN, or as-needed orders for antipsychotic drugs. The current rule is that the attending physician or prescribing practitioner may order PRN drugs, antipsychotic drugs, for 14 days. But after 14 days, the physician or practitioner will have to evaluate the resident. The guidance in the state operations manual says that needs to be an in-person examination. What CMS is proposing is to change the rule so that the prescribing practitioner or physician could order PRN for more than 14 days for antipsychotic drugs, just as the rule permits for the broader category of psychotropic drugs. Next slide, please. The rationale is very specific. Provider feedback says there's burden in having to have the physician come in after 14 days. They argue that there's a negative effect on resident care, especially in small facilities and rural areas, and that physicians would not be able to get in, and so care would be interrupted for residents. The preamble discusses the very important and quite excellent Human Rights Watch report from last year, They Want Docile, which documented hundreds of thousands of residents getting antipsychotic drugs inappropriately. But then, on the next slide, you see that CMS concluded that, echoing what the industry had argued, current requirements could result in interruptions of care, so they're going to have the same rules for antipsychotics as for psychotropic drugs. CMS does not anticipate any cost savings from this change. Next slide, please. CMS is extremely concerned, though, about the potential, what it talks about, the potential misuse of antipsychotic drugs, and it solicits comments on a number of questions that I think it's really important for people to try to respond to. They want to know whether their proposed change, allowing unlimited PRN orders for antipsychotic drugs, will provide sufficient protection for residents, and they want to know whether they should retain the current policy, what is the impact of the policy, and a variety of other things. So it's important that people look at that section of the preamble and try to submit comments with specific comments, specific examples of what you're proposing or what you recommend. Next slide, please. I think from our perspective, the concerns are that antipsychotic drugs have been, for a very long time, an extremely serious problem in nursing homes. We know they're overprescribed and they're misprescribed, and we've been hearing that for decades. The most recent report was the Inspector General's 2011 report, which said that more than 80% of the antipsychotic drugs were off-label and for diagnoses that the Food and Drug Administration has issued black box warnings for. Black box warnings is their highest level of warning, and it says, the FDA has said, that these antipsychotic drugs can kill people who have dementia. They are not appropriate for people with dementia, and yet that's who's getting these drugs. So I think it's a pretty serious concern. I just would note that when the proposed rule came out in 2016, it allowed the 14 days for an as-needed antipsychotic drug, but the proposed rule had said 48 hours. So there already was a tremendous expansion in how long PRN antipsychotic drugs could be prescribed. So obviously, I think this is really terrible policy. Next slide, please. The next issue we want to talk about is infection control. Next slide, please. This is a very important part of the regulations, I think, because we've always had requirements for infection control. This is not new, but they have not been very successful, as we'll see in a moment, in preventing infections. And so the 2016 regulations did a very important job of creating and requiring each facility to have an infection prevention control program, which would be overseen by a person called an infection preventionist. What they're proposing now, the proposed rule said, is that that person needed to be part-time, present part-time in the facility. And the proposed rule substitutes the language sufficient time in the facility. The infection preventionist must spend sufficient time in the facility. I think our experience in the nursing home world is sufficient hasn't been a very good way of getting adequacy. We certainly know we've had the nurse staffing requirement for sufficient staff to meet residents' needs, and most nursing homes don't have enough nurses. So I hesitate to think that sufficient time for the infection preventionist will be enough. Next slide, please. Again, the CMS rationale for this is the providers were talking about burden, and then of course CMS says most infection control deficiencies are cited as level D, no harm. I would just note that the facility in New Jersey where 12 pediatric residents died last year in 2018 had been cited with an infection control deficiency the year before, no harm deficiency. I believe it was also a level D. So that doesn't give me a lot of confidence that just because something is called level D, it's called no harm, means that there's really not a problem. Again, CMS does not anticipate saving any money from this change because it calls it a clarification. In fact, it says it's not really a change. Next slide, please. What's interesting to me is in the preamble, CMS repeats the language from the final rules in 2016 about infections being the leading cause of morbidity and mortality in the residents of our nursing homes. 1.6 to 3.8 million infections each year, almost 388,000 residents dying from infections in each year, and costing, between 673 million and $2 billion. The one part that they didn't put this year, that was in the 2016 rule, was that infections, they said in 2016, results in 150,000 hospitalizations of residents per year. So this is clearly a serious problem. Next slide, please. Again, CMS is explicitly soliciting specific comments on how to determine if the infection preventionist has sufficient time to devote to this task. It's important to get your best thoughts on this and really tell them what you think, if having the sufficient language is sufficient, or how do we determine what would be sufficient. It's important to comment on that. Next slide, please. This again, now we're moving to physical environment, and there are two parts of this. The first is the Life Safety Code. The final rules, not the nursing home requirements of participation, but Life Safety Code rules, in May 2016 adopted the 2012 edition of the Life Safety Code. But CMS says that 50 facilities would have to spend a lot of money, $4.75 million each, if they had to comply. So they're proposing to allow these facilities to continue using the 2001 rules. This is going to save $240 million, according to CMS. Next slide, please. The second part of physical environment that CMS is proposing to change is resident rooms. The 2016 rules required that newly constructed, reconstructed, or facilities certified for the first time after November 28, 2016, couldn't have rooms that had more than 2 residents per room. And it required that these newly constructed or newly certified facilities have their own bathroom, including a commode and sink. Next slide, please. CMS, again, is very concerned about the burden identified by industry stakeholders, and they're claiming that these requirements, which are so burdensome, they would discourage owner-operators from building, remodeling, upgrading, and purchasing facilities. So next slide, please. The proposed change says that the revisions should apply only to facilities that are newly certified, newly constructed facilities, and newly certified facilities that hadn't previously been long-term care facilities. And the estimate is $328 million in savings in the first year alone and less in subsequent years. Next slide, please. Now we want to shift to survey, certification, and enforcement, where CMS has taken a very, very different approach. In contrast to their approach with the requirements of participation for facilities, which involves relaxing or totally eliminating certain requirements, what CMS does with these sections is add more new and more prescriptive language to the requirements. Next slide, please. So dispute resolution. Currently, there are 2 kinds of dispute resolution, informal dispute resolution and independent informal dispute resolution. What CMS is proposing is to take the requirement from IIDR that the dispute resolution be completed within 60 days of a facility's request, if the request is timely made. They want to add that requirement to make it consistent for IDR as well. They want the IDR to provide a written record to the facility, and then if CMS disagrees with the recommendations of IDR or IIDR, they have to provide a written statement to the facility. CMS also proposes to add language from the State Operations Manual that surveys should not be uploaded to the Federal Survey CASPER system until the IDR or IIDR is resolved. Now, that's an interesting point. I guess they're saying constitutional due process means that facilities have some opportunity to contest a deficiency before it becomes public. But I would say I've been looking at Nursing Home Compare for administrative law decisions upholding deficiencies a couple of years later, and those civil money penalties don't even appear on Nursing Home Compare. So it's a pretty flawed system about what's reported, but CMS certainly wants to make very clear that facilities shouldn't have these bad results reported until they get through IDR or IIDR. Next slide, please. A second change CMS wants to make to the IIDR qualifications is to add language from the State Operations Manual that whoever is doing the reviewing needs to have a specific understanding of Medicare and Medicaid. So that's that proposed change. Next slide, please. For civil money penalties, CMS has an interesting proposal. According to the preamble, in calendar year 2016, 81% of facilities submitted written waivers of deficiencies. Once they got a deficiency, they submitted a written waiver, and then they got a 35% reduction in the civil money penalty. 4% requested a hearing before the administrative law judge. 15% did neither, and as a result, they were supposed to pay the full civil money penalty. What CMS is proposing is to create something that it's calling a constructive waiver of the right to appeal. So if the facility didn't appeal, it's just going to be assumed that they waived the right of appeal, and then they would still get the 35% reduction in the amount of the civil money penalty. Now, with the per instance being the main civil money penalty that's imposed these days, and that average is less than $9,000, we're talking about pretty trivial CMPs being imposed. CMS estimates that the total savings to facilities of this constructive waiver provision is over $1 million in annual savings, and CMS will save $125,000. So now I would like to turn this over to Lori to talk about arbitration.
So,
thanks, Toby.
Lori, can I just interject a couple of things real quickly? I inadvertently left out something related to food and nutrition, and I don't know how I could have done that because it is one of my favorite subjects in the entire world. But in terms of the Director of Food and Nutrition Services, the proposed regs would, I think, significantly relax the qualifications for that individual. The facility has to have a Director of Food and Nutrition Services if it doesn't have a qualified dietitian full-time, which is very often the case. So the proposed change would be, well, let me go back. Under the current regulations, in order to be a Director of Food and Nutrition Services, there are a number of possible certifications that an individual could have and qualify, or they'd have to have an associate or higher degree in food service management or hospitality, or maybe meet any state requirements for food service managers. But the proposed rule would remove those standards and allow a person to be a Director of Food and Nutrition Services under two circumstances. One, if he or she has two or more years of experience as a Food and Nutrition Services Director, or so that is to qualify by years of experience only, or if somebody has completed a course in food safety that covers topics that are, the language is pertinent to dietary operations. So no information about how long that course would be, how many hours, what else it would include. So wanted to make sure that everybody was aware about that proposed change as well. One last thing, just wanted to say that the proposed revisions will be impacting a number of the Phase 3 regulations that are the regulations slated to go into effect in November 28th of this year. So CMS has announced that implementation of most of the phase 3 regulations that are related to the designation and training of the infection preventionist, QAPI, and compliance and ethics will be delayed with some exceptions. So just wanted folks to know about the impact the proposed revisions are having on implementation. Now, Lori is going to talk to us about the final rule on arbitration agreements. So thank you, Lori.
Sure. Thanks, Robin. Hi, everyone. Next 2 slides, please, Alicia. So on the same day that CMS issued the proposed rules for the nursing home requirements of participation, they also released final rules around arbitration agreements, which we have been waiting for a couple years now to be released. So just to bring you up to speed on what's been happening around this particular issue, prior to the October 2016 final rules being released, or those rules becoming into effect, arbitration agreements weren't really addressed in the nursing home requirements of participation or the regulations at all. They were silent on them. But when CMS issued the 2016 rules, they include language banning pre-dispute binding arbitration agreements, which was great for consumers because we believe that they're unfair to consumers, and that consumers should have an opportunity not to have to sign them in advance, but be able to go into disputes with eyes wide open and then decide what the best course of action would be for proceedings. So, so the October 2016 rules banned the pre-dispute binding arbitration. Well, almost immediately, the nursing home industry went to court seeking and then receiving an injunction enjoining enforcement of this section. So this section banning the arbitration provisions has never been enforced. Essentially, it's like it never existed. And in December of 2016, CMS officially directed the state survey directors not to enforce those provisions while the lawsuit was pending and they were deciding what their next course of action would be. So they decided that they were going to reevaluate this section, and in June 2017, CMS issued new proposed rules around pre-dispute arbitration, which would allow the agreements and in fact allow that they could be a condition of admission for facilities, which was something we are definitely not in favor of. And CMS, when issuing the proposed rule, said that they felt it was an opportunity to reevaluate the provisions and determine if they could achieve a better balance between the advantages and disadvantages of pre-dispute arbitration. That's kind of what they were looking at. So lots of folks submitted comments. Next slide, please. And now we have the final rules that were published July 18th. CMS received more than 1,000 comments on this rule, which is pretty significant. The overwhelming majority of commenters recommended that CMS keep the requirements of the 2016 final rules prohibiting the use of these forced arbitration agreements. They felt that most of the commenters thought they were unfair to residents, and that because of the stress of and lack of understanding, the stress of the admission period, the lack of understanding of what these agreements meant, the fact that they were most of the time buried within the admissions agreements, that CMS should continue to ban them. But CMS decided that again, they were looking at balancing the advantages and disadvantages of the agreements, and in their own words in the preamble, they were looking to strengthen the transparency of the agreements and create protections against the abuses associated with the arbitration agreements, but essentially they thought that they should not be completely banned. And so that's what we're looking at with the final rules. And these final rules for arbitration become effective September 16th of 2019. So next slide, please. Let's go over what CMS has said in the rules. So as I mentioned, facilities may now ask a resident or their representative to sign a pre-dispute binding arbitration agreement. They are allowed. However, they cannot be required as a condition of admission nor as a requirement to continue to receive care in the facility. So that actually is a step in the right direction. The facility must explicitly inform the residents and their representatives of their right not to sign the agreement. So that has to be included in the agreement itself. It has to say explicitly that the resident and the representative do not have to sign the agreement. Next slide, please. Also, there are a number of requirements for what needs to be included in the arbitration agreements should the facility submit one to the residents and their family members. So first, they need to provide for the selection of a neutral arbitrator that is agreed upon by both parties, as well as the selection of a venue that is convenient to both parties. And that's often important because what we were seeing was that in these agreements, the facility would list who the arbitrator would be and what the venue would be, and that often was really burdensome also for residents and family members. So they are giving they are saying now that there needs to be the selection of a neutral arbitrator and a venue that's convenient. The agreements also must specifically grant the right to rescind the agreement within a 30 calendar days, so that if a resident or a representative goes in and they are signing the agreement, they have 30 days to either get legal advice, or if they determine that it is not in their best interest to continue having that agreement signed, they can rescind the agreement, and they cannot, since it cannot be used as a condition of admission or as a condition for continuing to receive care in the facility, nor is it a legitimate reason for transfer or discharge, they cannot be discharged from the facility for not having that agreement. So that's a really important provision that's been included in these final rules. The agreement also has to explicitly state, again, as I said, that neither the resident or representative is required to sign it. So these are some really important protections that have been included, I think, for residents and families. Next slide, please. The arbitration agreements may not contain language that prohibits or discourages the resident or anyone else from communicating with officials either at the federal, state, or local level, and that includes surveyors, it includes federal or state health department employees, and it includes ombudsmen. It specifically includes those three, but the language is federal officials. And that's important because it means that that residents and their representatives can still file complaints with those entities related to the same issue that they're having a dispute with the facility, that they cannot be prohibited from filing complaints with surveyors or complaints with ombudsmen, even if they are proceeding through this arbitration agreement with the facility. They still have the right to file complaints and talk to these other entities that can help them resolve problems. Next slide, please. Not only do the rules require that the agreement have in writing the specific provisions that I mentioned earlier, but there's also a requirement in there that, that the facility explicitly explain the requirements to the residents and their representatives. So the agreement must be explained in a form, manner, and language that the resident and the representative understand. And it is required that the resident or representative acknowledge that they understand the agreement. They also have to, again, explain that the resident or representative, if they do sign, that they have the right to rescind that agreement within 30 calendar days. So this is going to be critical in terms of what language they're using, what words they're using to explain what these agreements are. So that's something that we're really going to have to be paying attention to. How are they describing what does an arbitration agreement mean? What does it mean that they're signing this agreement? It's not enough just to say you're signing this arbitration agreement, which means that you can't file a lawsuit. I mean, they need to do better than that. And so this is something that we're going to have to be paying attention to and asking questions about how are they explaining it, how are the staff that are going over these provisions with the residents and family members, explaining it to them and what words are they using to make sure that they are explaining it in a proper manner and that the resident or representative actually does understand it. Next slide, please. So if a resident or their representative does sign an arbitration agreement and they actually have a dispute that is resolved through arbitration, the facility is required now to retain the signed agreement for binding arbitration as well as the arbitrator's final decision, and they must keep that on file for 5 years, and it must be available to the surveyors for inspection upon request. So in the preamble to the regulations, which great bedtime reading. If you've never just kind of gone through, you know, it's really, you get really great nuggets of information in terms of what CMS was thinking through not just the regulations, but by reading the preamble. So, you know, we really would suggest that you take the time to do that. But when CMS wrote this language, what they said in the preamble was that they want these documents to be available for inspection because it allows the surveyors to review the issues raised in the arbitration and to determine if they raise concerns about the quality and safety of the resident's care and the facility's compliance with regulatory requirement, and that surveyors can then incorporate problems identified through arbitration into the current survey in order to determine if the facility has taken steps to prevent the problem from reoccurring. I mean, that's really important information. So it is critical that these agreements be and decisions be made available for inspection. And CMS in multiple places in the preamble also says that it's then their opportunity to look at how these agreements are being used and what the arbitrator's decisions are so that they can start capturing data about the use of these agreements and then can be determining their impact on residents' care and on residents' rights. So that's also another important provision. So next slide, please. So what agreements are covered? This rule applies prospectively. So all moving forward from September 16th forward, any resident going into a facility that is presented with an arbitration agreement is covered under these rules. If a resident or their representative has signed an agreement already, and if it is valid and current, then it is still valid and current under state laws. But CMS does say, again in the preamble, and I have it there in quotes, we do believe it would be good policy, and they are encouraging facilities to offer current residents who've signed these agreements the opportunity to rescind them and proceed with a new agreement that conforms to these regulations. So, so let's hope, fingers crossed, right, that that's what's going to happen. So next slide, please. So as we move forward with these regulations, there's a real opportunity here to educate residents, families, and facilities about the rights and responsibilities and requirements around these binding arbitration agreements. And frankly, from our perspective, you know, families and residents really need to be educated about what it means if they sign these agreements, what their rights are, so that they really are going into this with open eyes, and frankly to tell them not to sign them so that they can have an opportunity to make a decision after a dispute arises when they can then decide what's going to be in their best interest. But it also gives them an opportunity to obtain legal advice, and so we would really encourage residents and representatives to obtain legal advice before signing these agreements, or absolutely within that 30-day window if they have already signed them. And it's important for us as advocates to be evaluating the language that is being used in these arbitration agreements that's being presented to residents and families to make sure that they are complying with the regulations, that they have the explicit language that's required. Also, how they are being presented to residents and their representatives and family members. Are they, again, using the language that the residents and their representatives understand? Do they understand the consequences of signing these agreements, and how is that being presented to them? So that's something that as advocates I think we really need to be doing. So next slide, please. With that, I'll turn it back over, Robin, to you and Alicia for questions.
Okay, thank you very much, Lori. So we want to give you all a chance to ask questions. And again, to ask a question, type your question into the Q&A box. And I want to just take a quick moment to introduce Alicia Lineswala, who is our public policy and program specialist, who's been assisting with the webinar and is helping us with asking your questions. So Alicia, do we have any questions at this point?
Yeah, we've had some come in throughout the webinar, so thanks to everyone for submitting some questions. So I'll get us started. Someone asked, can you give us specific examples of how these proposed regulatory changes would threaten or reduce quality of care? So I think that question could go to any of you, so feel free to jump in.
So this is Robin. I'll just start off, and I think a specific example is the proposed reg that Toby discussed related to PRN use of antipsychotics and renewing the order. The fact that a physician would no longer have to evaluate somebody on site. This makes it easier for facilities to use antipsychotics, and it's going and having. I think Toby talked about how harmful these medications are. So certainly, I think this is a step toward decreased quality of care and places residents, I think, at greater risk. CMS has an initiative, a national partnership to improve dementia care, and has been working to reduce the inappropriate use of antipsychotics. And I think this is, sadly, this would be a major step in the wrong direction and would be very harmful to residents. So I will let my colleagues jump in as well.
So I think another provision that would affect the quality of care is related to the infection preventionist rule, where they're just talking about sufficient time in the facility, and that gives an impression that there's less attention being paid to the particular provision if that person is not there on site. And considering some of the data that was shared today as part of the presentation, infections are a very serious problem. It's one of the top issues cited by facilities, and we should be doing more to prevent infection, not less. And by having what we know by facilities is if they don't have a specific requirement that they have to meet, that they're not going to meet it. And so sufficient time seems to be an inadequate standard, as we've seen in the staffing standards. So that puts less attention on the infection prevention program in the facility.
I think the transfer and discharge is also a concern. I mean, the rule that we're talking about is only giving notice to the ombudsman, but the preamble says if the resident doesn't object, then it's not a facility-initiated transfer. And we can see that type of non-objection being used by facilities to say we don't have to give notice to the ombudsman. And, you know, if they'll say, well, you knew when you came in that you were going to be here for short-term rehab, now your rehab is over, and so you need to leave. Didn't you agree? And people we know are not going to object. So I'm concerned about that. I'm concerned about the grievance procedure. To say that there's this general feedback or complaint that is different from a grievance is really a problem. It's going to be very hard to get something called a grievance. Do you have to use the magic word grievance, like Groucho Marx? You know what? Say the magic word to get a grievance. Otherwise, the whole system is sort of not applicable to you. I think they're just lots of small cutbacks that are not going to help. They're not intended to help, and they're not going to help. And CMS says at the beginning of the preamble, we want to be a better business partner. That's not what a regulatory agency is supposed to do. It's their responsibility is to make sure care is good for residents, not to be a business partner with the industry. So I think, by their own terms, they're not really trying to make care better. They're trying to reduce the burdens on facilities.
Great, thank you. So that's a good segue into a question about the grievance official. Someone asked, what recourse do we have for retaliation if that happens as a result of a complaint without the grievance official?
Could you repeat that?
Sure. So the question is, without a grievance official, what recourse do we have if retaliation happens?
The grievance official, the title is technically eliminated, but there still has to be a person, an individual who's responsible for overseeing the grievance process. So the recourse would be to go to that person and voice concern about retaliation. So we haven't totally lost the individual. We've lost a lot of the specific duties, we could lose, I should say. I would say to still go to whoever they are saying is responsible for handling facilities grievances, sorry.
I would say the language also in the rules that a resident or family member or representative has the right to file a grievance without retaliation or fear of retaliation continues to exist in the regulations, and that they still, if there is a concern about retaliation, they still can file a complaint with the Ombudsman program or with the survey agency. So that exists as well.
Great, thank you. So a question about arbitration. Do the facilities have to verbally tell residents that they have the right to not sign arbitration agreements, or is it just stated somewhere in the actual agreement?
It has to be both. It has to be written into the agreement itself, and they have to explicitly be told that they don't have to sign the agreement.
Great, thank you. The next question is also about arbitration. What matters can be included in the arbitration agreements, and specifically, would this include the residents' rights section?
Any provision can be included. Any dispute would have to go to arbitration. So any dispute that the resident has with the facility that they might otherwise consider filing a lawsuit about would have to go to arbitration if they signed this binding agreement. But remember that even if they signed the agreement, they also, regarding whatever dispute they have, can file a complaint with the survey agency or with the Ombudsman program as well.
Great.
But there are no limits on what the dispute is that would go. The thing is, with the binding arbitration agreements, essentially it says that if there is a dispute, that you want essentially a neutral party to decide for you what the outcome is going to be. Generally, your choice is to go to court, file a suit in court. But if you sign one of these agreements, that ability is taken away from you, and you have to go before an arbitrator, and that person will decide the dispute for you.
Okay, thank you.
So I think, unfortunately, that's all the time we have for questions, since we want to wrap up in the next couple of minutes or so. So thank you to all of you for your great questions, and thank you, Alicia, for selecting them and facilitating them. So we want to talk in the remaining time about what can you do about it? So what can you do about the proposed rules, and what can you do about the final arbitration rule? So next slide. So your advocacy around the proposed nursing home regs is going to be critically important. So the top 3 things that you can do right now to safeguard future protections and quality of care for residents is to comment, comment, comment. So by comment, I mean submit written comments to CMS about the changes that they're proposing, and talk about in your comments how they will affect nursing home residents. So the process is whenever there are proposed regulations that are published, there's a public comment period, opportunity for anyone to express their support or opposition. The comments have to be in writing and they have to be submitted by the deadline that's set by the government. And in this case, CMS has said that comments are due by September 16th, 2019. Next slide. So I really want to stress how important your written comments are. But we're not leaving you out there alone to do this. We will be there to help. We'll be preparing sample comments that you can use. We'll prepare them so that individuals can send in comments, or groups or programs like a state ombudsman program or a local ombudsman program could submit comments. And we'll give you guidance about where to submit, when to submit, and how to submit those comments. But I just want to make a few comments about comments. First, we're going to, as I said, provide comment letters to you to make that commenting as easy as possible. But what we know is that CMS does give, seems to give less weight to a sample comment that is absolutely identical to another sample comment. Now, I'm not saying no weight, but less weight. So the real gold standard, of course, is to write your own comments, use your own examples and observations to support the position you're taking. But if you can't do that, the next best thing is to try to personalize the template that we provide. So, indicate who you are, if you're a resident or an ombudsman, and draw from your own experiences and observations, and add that to the points that we make in the letter. So the more personalized and individualized, the better. But I want to be very, very clear and really stress that something is better than nothing, because among other things, comments are counted. So if there's no other way for you to get comments in than to use the sample template, then use the sample template. And I want you to know that comments can make a difference. Lori was talking about looking at the comments that were submitted for arbitration, and she shared with me that she was really struck by the fact that the overwhelming majority of them were submitted from advocates, and those comments really had an impact. So let your voice be heard. Next slide. So in terms of what you can do about the final arbitration rule, I'm just going to refer back to the 3 E's that Lori mentioned: educate, encourage, and evaluate. We will be preparing materials and doing more training in the coming months to help you with all those activities. Okay, next slide. So just in closing, I would say that I guess we all have our work cut out for us. It's going to be a very, very busy few months, but we can do this. We can advocate, we can educate, and we can do what it takes to protect nursing home residents. So here's our contact information if you have questions or if we can help in any way. I want to thank Eric, Toby, and Lori for such wonderful and helpful information. And I want to thank all of you for taking the time to join us today and for all that you do every day, day in, day out, to help residents. So look for information and action alerts coming from us, and enjoy the rest of